is No Spin Live. We're going to talk about medical tourism gone very wrong. Medical devices now under fire. And finally, breast implants and ALCL. And we've got a great, superb panel of experts here to share insights and tell us the real deal. We've got my chief resident from UT Southwestern, Nate Villanueva. Nate, great to have you here joining us. And Dr. Jason Posner from Boca Raton. Jason.
Hello, Bill. Hello, Nate.
Dolphins, they're doing well, Jason. Good. And then last but not least, we got Dr. Louis Rios from Edinburgh, Texas, fellow Texan. Louis, how are you?
Good. How are you doing, Bill? Good to be
Excellent. Here. We're going to talk about the first one. This is about medical tourism. It's just a terrible story. A lady from Dallas went to Mexico for a cut rate plastic surgery procedure, rhinoplasty, and she's now dead. So it's tragic. But Jason, lead us off on this one.
There's always risks involved in having any surgery. It's how you're able to handle some of the complications that may arise. In this particular case, the case sounds like the patient had an anesthetic complication and it was handled very poorly by the clinic and the resultant hospital that she was admitted to. So I think that was part of the issue. So it's not just the doctors where you're going to, it's the hospital systems in the area that are able to handle some of the issues that unfortunately may arise. We have a little higher standards in the U.S., a lot of accreditation issues that we have to go through, our anesthesiologists have to go through. So I think, potentially we have a higher safety rate here, but things can happen, and I think we all have to be prepared and go through drills and have things in our office. I mean, we're all accredited operating in our offices, and I think that just things that we have to go through are very important to keep our patients safe.
Yeah, so Nate, there is some good studies that are out there, and I know you're up on those. Why don't you share what the studies have shown about medical tourism?
Yeah, so there's, as with anything, there's always risk with surgery. And, there's a study that came out in September in the Annals of Plastic Surgery out of the University of Columbia. And what they ended up showing was that there's a cost associated with any type of complication. And the complication that they looked at in particular was atypical mycobacterial infections related to cosmetic tourism. And they looked at a group of patients and they found that they did a cost analysis and they looked at how much the patient saved initially on surgery, which was about $5,000. And then they looked at how much, after having one of these infections, how much the cost to the healthcare system was. And that cost went from saving $5,000 to costing the healthcare system about $90,000 plus per patient. That's not including costs associated with lack of going to work and missing work and time like that. And they kind of estimated that at another $20,000 to $30,000 more on top of that.
I think all of us have experienced this, where I get people who come from several hundred miles away because maybe their families live in my town and they might want to have a tummy tuck, for example, and they may be from Dallas, 500 miles away from me. And I'll tell them, look, I know 50 plastic surgeons in Dallas. You might be better off because a big part of the care is involved in the post-operative care, which people don't tend to kind of think about. And then if complications occur, you don't want to be 500 miles away from your surgeon. But I also kind of want to go back to this issue with the medical tourism, because I'm right on the border. So, so I see kind of what's happening, the back and forth ebb and flow. Now, again, we don't want to denigrate our Mexican plastic surgeons because we have a lot of great trained Mexican plastic surgeons. They teach at our meetings, they spearhead courses, they do research and help us out a lot. They're having the same problems that we're having here in the United States. They're having non-plastic surgeons trying to do plastic surgery. So like in this case, apparently the price was 1/3 of what it was in the United States. And a lot of times that's an indication that the person who's doing the surgery is not a plastic surgeon. And in this case, the person who was doing the plastic surgery actually ended up being a dentist. And so I think, as far as, warnings for the general public, when you do see like these cut rate prices across the border, it may not even be a plastic surgeon that's doing the surgery in these medical tourist locations. And that may be the reason why the prices are so low. My experience here on the border is that the real highly trained, board-certified plastic surgeons that have good, consistent results, their prices are somewhat similar to our prices.
I think those are great points. This is, again, it's a tragic ending to a story, and it's unfortunate that people pay attention to things when you have to have some tragic ending like this, but certainly patients that are considering going across the sea or going to some other remote location just need to take all these things into consideration, because oftentimes just the price is a bad factor to base your full decision on where you're going to have your surgery. So
it goes back to you get what you pay for, no matter what. Always comes down to that.
All right, well, let's move on. These next two stories are related. It actually comes out of a story that was done by a group called the ICIJ, the International Consortium of Investigative Journalists. And so this first part was aired on NBC this weekend, and it was about doctor kickbacks on medical devices and the medical device approval process. So Jason, what did you think about this? And I think there's some really important takebacks that patients and our viewers should know about.
Look, we're not orthopedic surgeons where we're placing metal pieces of instead of bones that cost tens of thousands of dollars. Most of the things that we use are relatively low cost. No company pays us to use their products. Allergan doesn't pay me to put an Allergan breast implant. I pay Allergan to use their breast implants. So I think when you really look at this product, maybe this was a story of a younger gung-ho guy promoting a product a little bit more than probably he should have. But that's how progress is. We do research for different companies, and we do get paid for our time doing research. But we're all adults here, and we all have certain ethical standards. I don't choose something based upon whether I did research for that company or not. I choose something whether that something is a good product for that particular patient.
The thing is that, like, for example, you've done a lot of work with a lot of different non-surgical devices and surgical devices, but a lot of that has to do with you have a distinct expertise that you've built up over 20, 25 years, and you're able to look at these things and study them. So there's a difference between, say, working with industry and studying a device versus just doing promotion, correct?
I think also, like, if you look at my disclosure list, I just tell everyone, I work with everybody. So, it's not like I'm in one camp and promoting one company. I work with multiple companies on development for a lot of different technology. And I'll get up there, and sometimes the company I'm working with, I'll say, this is not the best product for that doctor. Being in practice over 20-something years, what do you have left at the end of the day? It's your ethics, and I don't want to go to a meeting and talk to my peers and them telling me, you told me to buy this product and it sucks.
And Louis, there's a lot of people that do think that there's issues with conflict of interest in medicine. The truth is there's conflict of interest everywhere. There's even conflict of interest for the journalists that publish articles like this. NBC and ICIJ need to sell copies and sell airtime in order to be alive and be a thriving company. So there's conflicts everywhere. But what do you think? And do we have a problem in medicine and specifically plastic surgery?
I don't think overall that there's a general problem. I think in any industry, in any profession, there's probably a few bad apples here and there. I'm not saying the plastic surgeon was one of them. But you might see that here and there. But I think, like in our specialty, we really go out of our way, especially like in the meetings when we have our talks and our discussions. We always have to put up slides disclosing, any, I wouldn't say conflicts of interest, but, any investing that we do so the people listening will know where we're coming from. I know that locally there's a doctor-owned hospital, which I'm not part of, but all of the doctors there display the fact in their waiting rooms and to their patients that they're owners of the hospital. I don't think that any of us would have any problems, if it was required, if it was a law for us to, have something in our waiting room or tell our patients, hey, look, I'm a paid consultant here and there. Because I think I agree with Jason. I don't think that really, for the majority of us, doesn't taint our decisions. We want the best results for our patients.
So Nate, as a young surgeon, you're in your last year of training, you'll be going out into practice next year. What's your perspective on this? Do you guys talk about this at your level and going out into practice? What do you think?
Yeah, so actually starting in medical school, we got talks about be careful of the drug companies, be careful of these people because they're going to try to buy your decision. And so early on, and even in our medical education, before we even got to residency, we were warned that this is, an ethical issue, to be careful, to be cautious, and always do the right thing for the patient. And I think that going through residency, we've met a lot of industry, and for us, it's important to spend time with these companies to learn about their products and to learn how their products could potentially benefit our patients. But by no means do I think, and I believe that, would we ever make a decision based on a company buying us a dinner or taking us out for, to discuss their product. I think the most important thing is what's going to benefit our patient, and if that device or that product will benefit the patient, then we'll make a decision that's to their favor.
It's definitely a complex situation, and there is probably some abuse of the system overall in medicine. There always can be things that can be done better, but in general, it's really not a big issue. And in fact, some of the work and research that's done with industry is critical to advancing care and outcomes for patients, and that's what it's about at the end of the day. So let's move on to the last story, and this again comes out of the same umbrella, the ICIJ examination of medical devices. So this is about breast implants and ALCL, and basically what they propose is that people have been hiding what's been going on with ALCL, and that the incidence is much higher, than it's kind of been swept under the rug a little bit. So Jason, what do you think about this story?
The issue is it's a disease that takes a long time to become manifest. So you wouldn't know within a year of putting an implant on the market. This stuff comes years and years later. So only now are we starting to see what happened 10 and 15 years ago. So it takes time to accumulate data. And I think the plastic surgery societies have done a fantastic job, Bill included, of putting together task forces to evaluate this, to look at best practice scenarios, to figure out how to treat, what the cause is, and how to prevent. So I think we've been all over it. I think every meeting I go to, we talk about it and how to prevent this. And it's changed my management of patients a little bit. I pretty much use a smooth-walled implant now, where I might have done a few cases with a textured implant in the past, and we've discussed that a lot on this show. But I think it's definitely affected how I perceive things, how I'm on the lookout for certain patients that might present with a certain presentation, and how to treat them if they come in. So I think we're all over it. I think we're doing a damn good job of assessing this new problem and treating it.
So Louis, is this? Do you feel like that this is something that people have been hiding from patients?
Absolutely not. I mean, I agree with Jason completely. I think that we've been really upfront with this. Our societies have been upfront. With our Aesthetic Society and our Research Foundation, we're giving a lot of money to do research here. We're developing registries and automating it, and doing really some cutting edge stuff so we can wrap ourselves around this. We're educating surgeons. The only thing I think we can do a little bit better maybe is encourage our surgeons to have, include this in the discussion when you're talking about breast implant surgery. Include it in your consent form so that your patients are concerned. Now, we don't want to, over scare them, because, we don't know the exact incidence. I mean, we've seen 1 in 500,000, we've seen 1 in 3,000, is it textured or not? But I think we do need to include that in our consent forms. And I know we're really emphasizing that with the surgeons, but, if anything, I've really seen our societies just take this issue head on. And Bill, you've been one of the leaders here. I think we've learned from the past, in the 1990s with the implant issues, that we really need to be the leaders and do the research independent from the companies to get the real answers.
Nate, as a chief resident, what's your perspective?
I think the story is important just so patients are aware. I think the sensationalism of it makes people worried because they focused on the number of deaths and they really scared the patients and people out there, which I think should not be done. I think it should be more of an educational thing. I think, the discussions that we've had, we're fortunate to have worked with you and learned all about this a long time ago, and it's something that in residency it's very common knowledge, and it's something that you discuss with your patients if it comes up, and we know how to carry on those conversations. But I think you know, in general, I think the conversations need to be had. The patients need to be made aware that this is something that can be done, and you educate your patients on what the signs are.
Yeah, I think, Nate, you're right. Awareness is really key. And actually, Michelle, who was on the NBC story, also did a great job in this story, and she did a great job in the Plastic Surgery Channel, a deep dive on breast implant ALCL. If you want to see more of her, you can go to Plastic Surgery Channel's deep dive on breast implant ALCL, where we had 3 patients on. And you know, she talks about awareness too on this piece, and that is key, because we do know that there are surgeons out there, usually probably not plastic surgeons, but because these people present to ERs and they present to their family care doctors, and they may not be aware of it, and then there can be delays in diagnosis, which we know can change the outcome of the patient. So awareness is key. And probably awareness beyond just the scope of plastic surgery. So I think that's an important message. I would like to see these stories be a little more balanced, however. You know, when they're using people as experts that are, you know, had multiple lawsuits or had their medical license taken away, it takes away the credibility of it, especially when they have no other side of the story. The question is, in this story, they talk about textured implants. Should they be banned, or should they be banned, Jason?
No, they shouldn't be banned, but they're under study. We're evaluating what's the problem. And look, the physicians should be able to make a decision as to what's best for their particular patients. And the studies that are coming out from all of our societies are able to help guide us to get us the best product for that particular patient. And there's still maybe instances where a textured device might be a better device for that particular patient.
Louis, texture, should it be banned?
I don't think we're there yet. Again, I kind of agree with Jason that we should let people decide, you know, what they want to do. But I'll tell you this: I've been using smooth implants for 20 years. I like them. I don't see any problems with them. I do know some colleagues that were using a lot of textured implants, and so when this issue came up, now they're having to kind of, you know, go back and deal with that with, you know, former patients. But I think, you know, going forward, you know, having the discussions with the patients, I think you can really have a good consent, you know, from here forward.
And I would say that it is the complete wrong decision to say you're going to solve this by getting rid of textured implants. In fact, I couldn't agree more. I don't know, Jason, I think you said it, that the decision to use texture is a decision between the patient and the physician. And there may be some circumstances where a textured implant is indicated. All right, well, listen, that's some great stuff, guys. And if you want to see more of this, you can see it on the plasticsurgerychannel.com.